Please. Thank you, sir. Thank you, Dr. Banerjee and respected chairperson, Professor Das Bishas. He used to be my teacher and many senior people over there. So quality of life, is it important? So these are the table of content by which I'm going to, distribute my talk. So how important the improvement of quality of life. Recent guideline recommendation regarding the treatment of heart failure with reduced ejection fraction patients, role of ARNI, sacubitril valsartan, in improvement of quality of life, as well as the same molecule, how it improves the clinical outcome, overall clinical outcome in this group of patients, followed by conclusion. So why improving quality of life in heart failure patient should be one of the key management objective. Let us go through that. So many a time, whenever we give talk, we discuss about heart failure with reduced ejection fraction. We are very, very concerned about the outcome because this is a high mortality situation, 50% mortality at the end of 5 years. But seldom we ask the patient about their personal, very, very personal thing. How is the quality of sleep? How is the sexual life of the patient? Heart failure is not a good thing to have. So is the patient suffering from depression, any other psychological issues or not? And yes, fatigue, shortness of breath, edema, this thing we do take care, but many times these are often neglected issues in heart failure patients. So significantly reduced score of quality of life has been shown in different trials to be directly related with the long-term outcome of the patient. I'll go through a few important data. This is the data from Alberta Heart. So heart failure leads to decline in the patient's quality of life over time. And this is the clinical evidence which suggests that 32.4% of heart failure patients experience a more than equal to 5-point worsening of the Kansas City quality of life overall summary score at 12 months. So that is a very, very significant information and piece of evidence. Now, what is the impact of quality of life impairment on heart failure outcome? I already mentioned it has direct correlation with the long-term outcome. So composite outcome of mortality or heart failure hospitalization were inversely related to the quality of life score. So though there is no direct correlation, but indirectly, it also leads to improvement of the mortality and morbidity of the patient. Now, the same piece of data also suggests that patients with greater impairment of quality of life showed higher risk of mortality and heart failure hospitalization. There was 1.5 times higher risk of mortality and heart failure hospitalization in heart failure patients who had experienced a 5-point decrease in the Kansas City quality of life score. And also the mortality rate increases with the heart failure patient with higher NYHA class and greater impairment of quality of life. And global congestive heart failure study incorporating 23,000 patients from 40 countries has given us this information that 1.17 time increase in the risk of mortality in part 10U decrement of the quality of life score and also 1.14 time increase in the risk of mortality with the same sort of individuals. So in a nutshell, poor quality of life in patients with heart failure is linked to negative clinical outcome and also it linked to high rate of mortality and recurrent hospitalization. Therefore, regular assessment and improving the patient's quality of life plays a very vital role in improving their clinical outcome and also the better management, overall management of the heart failure and reduced ejection fraction patient. So what about the guideline? Are they silent about the quality of life? So this is the 2021 ESC guideline. They mention that assessing quality of life is one of the vital components in heart failure management program as recommended. So nowadays they give importance to the psychosocial problem, apart from the normal usual heart failure marker. So psychosocial problem, sleep, sexual activity, everything has been taken, given importance. So recent guideline, this is the overall guideline of heart failure with reduced ejection fraction, 2021, it's all same, but few new things because ACE inhibitor, ARNI or beta blocker, MRA, they are class 1 medicine along with the SGLT2 inhibitor, but few ARNI becomes a cornerstone therapy in this group of heart failure with reduced ejection fraction patient. And it's very important to understand ARNI may be considered as the first line therapy instead of ACE inhibitor in all heart failure patients. So de novo initiation of ARNI is now a class 1 recommendation as per the all the recommendation bodies, including ESC as well as ACC. And initiation of sacubitril valsartan in ACE inhibitor naive patient with heart failure with reduced ejection fraction has been recommended to be considered. And not only that, They also mentioned it can be even started or initiated in hospital. Why in hospital? Because only that then it is possible to take care the immediate post-discharge 1 month period. So that is why the guidelines are very slowly changing. ACC 2022, they also have similar kind of recommendation in favor of sacubitril/valsartan as the first line therapy for all heart failure with reduced ejection fraction patient. And the chronic symptomatic heart failure with reduced ejection fraction, ACE inhibitor ARB, if already the patient is on ACE inhibitor ARB, it should be, replaced even if the patient is asymptomatic. Why? Because that can take care of the, further reduction of sudden cardiac death and long-term outcome and mortality benefit. So heart failure, reduced ejection fraction therapy and their impact on quality of life, what evidence do we have? So improving quality of life is a target for increasing interest when evaluating heart failure therapies, and first-line that have been shown to improve the disease prognosis have had mixed results with respect to quality. Let's see how the other class 1 recommendation drug, do they improve? Do they have any effect on the quality of life? Now, beta blocker do not improve quality of life. So that is for sure. We do not have any evidence in favor of beta blocker, and there is mixed result with ACE inhibitor and ARB. So sacubitril/valsartan has shown to improve the quality of life consistently across different trials. So role of sacubitril/valsartan in improving the quality of life in heart failure patient with reduced ejection fraction. So it helps improving quality of life, functional capacity. So improvement of quality of life and functional capacity has been documented with improvement of the Kansas City quality of life score, peak VO2, 6-minute walking test, respiratory efficiency, and domestic activity as well as sexual activity. These are evidence which we are having. All the important parameters of quality of life has been shown to be improved with ARNI, and that is very, very consistent result. And if we see further, it helps this kind of patient to feel better and be active. There was significant change in the score difference with sacubitril/valsartan compared to original analysis at 8 months. So even in long run, it has consistent improvement. So following initiation of sacubitril/valsartan, improvement of this quality life score occurred early within 2 weeks and were sustained across a 12-month follow-up. So that is very important, very early improvement, and that improvement actually is getting sustained. So very, very robust, important data. And it has also showed that greater improvement of the quality of life compared to ACE inhibitor and heart failure, ACE inhibitor and ARB. And there was 4.5 points greater improvement in the overall score with sacubitril/valsartan compared to NRP. So this is the evidence which we are having. Now, sacubitril/valsartan also helps the heart failure with reduced ejection fraction to live longer. Treatment with this molecule, mean improvement of survival is around 9 years. So that is very, very important. Not only they are getting a better quality of life, they are living longer. So assessing whether your choice of therapy is improving patients with quality of life made easy. So this is a kind of journal which is available. If you can ask your Novartis guy, you can get it, and some of the hospital already has implemented. Our hospital, we have it, and by this, if you implement it, you can see clearly how much improvement of quality of life actually is happening to your patients. Additionally, sacubitril/valsartan improves the clinical outcome. So this molecule helps your patient to live longer and stay out of hospital. At the same time, it also improves the quality of life. So this sacubitril/valsartan, along with other GDMT, shows superior reduction in mortality. Can it be combined with other molecule? There is clear-cut evidence that 62% reduction in the risk of all-cause mortality with sacubitril/valsartan, along with beta blocker and mineralocorticoid receptor antagonist in this group of patients. And at the same time, 42% reduction in the risk of all-cause hospitalization and along with sacubitril/valsartan, a beta blocker and MRA are actually being co-prescribed. So they can be co-prescribed with other class 1 molecule, and it has shown to improvement of the cardiac function. So not only the quality of life is getting better, the mortality is coming down, survival is improving, but also echocardiographic parameter. We all know that whoever is using this molecule, there is consistent improvement of the ejection fraction. In the study, it is shown that 12.8% improvement of the ejection fraction if we use this molecule over a period of 12 months. And not only that, the parameters of echocardiography in systolic volume, in diastolic volume, in systolic diameter, in diastolic volume diameter, everything actually has a very consistent improvement after 12 months of continuous use. So if I summarize, improving patients' quality of life should be considered as an important aspect while managing all heart failure with reduced ejection fraction patient. So we should initiate sacubital valsartan in heart failure with reduced ejection fraction patient with confidence. It will improve the quality of life. It will improve the physical and social activity. It will improve the clinical outcome. It will improve the cardiac function as well. So with that, I'd like to stop here. Thank you very much.
Thank you, Arindam, for your very elaborate and very good discussion. Just I initiate the question, only a few questions. The question from my end is that which particular subset of patients with heart failure with reduced ejection fraction who are best benefited so far as the quality of life, which is your main object in speaking, which subset of patients are best benefited so far as quality of life is concerned from ARNI?
So which subset you meant to see the, different spectrum of
Yeah,
fraction?
actually,
Or NYHA class?
Anyway, you can tell the NYHA class or the ejection fraction.
So the study shows that the benefit in terms of improvement of quality of life is seen across the board, irrespective of the NYHA class, irrespective of the ejection fraction. But yes, someone who is very, very symptomatic, class 4 symptomatic, we do not expect that this the gentleman or lady is going to have sexual activity. So we should not, jumbled up our expectation also, but rather a patient who is, class 2 symptomatic. If we initiate this molecule, probably his sexual life can be better. So rather, in a very advanced heart failure patient, symptomatic patient, we should focus on the sleep or the mental anxiety, depression, anxiety. Those parameters might get improved better way. So different, component of quality of life, we should focus in different subset. Advanced heart failure symptomatic subset or lower symptomatic subset.
Another thing, as Dr. Banerjee was talking about, when you are discussing about the improvement, it is hardly not alone because we often use multiple drugs. So the whole team of drugs are responsible for the improvement of the patient.
I fully agree with you, sir. We should try to give maximum number of medicine because this is not a good thing to have all the molecules which are shown to improve the mortality. But if we look into the evidence, the improvement of quality is there only with
I was coming to
other molecule, though they have very
that you have highlighted the issue of quality of life besides the longevity. Initially, other studies have been mainly focusing on longevity, but newer studies, they are highlighting the issue of quality of life. And you have already shown that the quality of life is related to many aspects of the patient's well-being. So it could be physical, social, and psychological and emotional. All these components are very important. And we all know that the prognosis of the heart failure has now become even worse than many of the malignancies. Initially, it was likened only with the malignancies, but it is now with the development. Fortunately, we have got ARNI now, which is showing some evidence in favor. Now, the issue is how to use ARNI. This is also very important. When you are talking about improvement in quality of life, do you think it is dose related, that you have to escalate the dose, or you just fix up, start up, keep it there?
So
what's the message to the audience?
Yeah, I feel the evidence suggests that we should always try to build up the dose because maximum benefit is seen at highest dose. But even if we cannot achieve that highest dose, the recommended dose, rather 200 milligram twice a day, whatever dose we achieve, will get better benefit compared to ACE inhibitor. So that should be the message to the audience.
So the message is guideline-directed medical therapy. First of all, the attempt should be, if it is not possible, at least maximally tolerated dose.
Yes.
The essence is whatever possible to give it. Don't refrain from giving it. So that is very important. And do you think, you have highlighted the issue of ARNI, beta blocker, diuretic, MRA, etc. Any thought process about Verquvo?
Verquvo is a new kitty in the treatment of heart failure. Verquvo, as we all know, it has been evaluated in worsening heart failure patients. As of now, we do not have any evidence in chronic heart failure patients. So worsening heart failure is a different entity. All the guideline, ESC, ACC, they are now focusing on the worsening heart failure. This is because important entity. It has some strong correlation with the mortality of the patient. In those group of patients in Victoria trial, where QO was evaluated, there is another very large trial which is going on known as Victor trial. As long as we do not have the data from the Victor trial, we actually
days
not
are
in a
coming
position.
when we will be not waiting for worsening heart failure. It is another member it will be given because it is easier to give. Potassium, creatinine, BP, these
Blood
are
pressure.
not the major hindrances, which often become a hindrance in case of hernia.
I fully agree with your point, sir, but we do have evidence only.
We have to wait for some time.
Yeah, we have evidence only in worsening heart failure patients as of now. In future, these points are very
Question
important.
from the audience.